Schizophrenia and bipolar disorder are serious mental illnesses that affect millions of people worldwide. Although there is no cure for either condition, medications known as atypical antipsychotics can help control the symptoms of these debilitating diseases. Dysfunctions within specific areas of the brain are thought to play a role in the development of schizophrenia and bipolar disorder, as well as producing the side effects associated with some therapies. Disturbances in the prefrontal cortex are thought to relate to the negative and cognitive symptoms of schizophrenia, such as withdrawal, apathy, a lack of emotional expression, reasoning, and perception. In people with bipolar disorder, disturbances in the prefrontal cortex may account for the lack of energy and sadness associated with the depressive episodes. Dysfunction within the limbic system is thought to be responsible for the positive symptoms of schizophrenia, in which patients experience delusions and hallucinations, and the emotional and behavioral disturbances of bipolar disorder. Because similar symptoms may occur in both schizophrenia and bipolar mania, it is thought that disturbances in the limbic system play a role in both diseases. The serotonergic pathways in the limbic system, the striatum, the prefrontal cortex, and the cortex are thought to play a role in the symptoms associated with bipolar depression. The effects of some drugs within the striatum are thought to contribute towards the distressing group of symptoms that some medications produce. Known as EPS or extrapyramidal symptoms, these symptoms are associated with involuntary muscle movements. Some medications can also affect the anterior pituitary, causing an elevation in the levels of the hormone prolactin, which is produced by this gland. Increased prolactin levels can lead to hormonal side effects, such as sexual dysfunction in both men and women, menstrual irregularities and lactation in women, and in men, breast development and loss of libido. However, it is in the limbic system where most of the primary effects of schizophrenia and bipolar mania are believed to be generated. The atypical antipsychotic Seroquel is a clever molecule with a unique receptor-binding profile. Abnormalities involving the neurotransmitters dopamine and serotonin are thought to be important in both schizophrenia and bipolar disorder. Newer antipsychotics have a stronger affinity for the serotonin group of receptors than for the dopamine D2 receptor. This may be the reason for the minimal involuntary muscle movement side effects, as well as the low incidence of prolactin elevation and related sexual side effects observed in patients taking Seroquel across the dose range. Importantly, Seroquel has a preferential effect on the D2 receptors in the limbic region, in contrast to those located in the striatum. Since the striatum is important in controlling muscle function, this preference for limbic D2 receptors may explain why Seroquel is able to reduce the positive symptoms of schizophrenia and the symptoms of bipolar mania while minimizing the involuntary muscle movement side effects that can be so disruptive to patients' lives. There are also important differences in the way in which dopamine is released in the striatum and the limbic system. More dopamine is released in the striatum than in the limbic system. In the striatum, Seroquel binds to the dopamine D2 receptors. In addition, Seroquel binds to the 5-HT2A receptor, which triggers the release of more dopamine in the striatum. The release of so much dopamine displaces the Seroquel from the D2 binding site, allowing dopamine to bind. Since it is the blockade of the dopamine receptors in the striatum that is the cause of the involuntary muscle movement side effects, Seroquel's clever mechanism of action allows dopamine to maintain its normal physiology in this area of the brain. This may be another reason for the low occurrence of the unpleasant involuntary muscle movements observed in patients taking the drug. In the limbic region, Seroquel blocks both the D2 and 5-HT2A receptors. But unlike in the striatum, this blocking of the 5-HT2A receptors does not trigger the release of more dopamine. The Seroquel and dopamine molecules will share binding to the D2 receptors. In addition, there is less dopamine release overall in the limbic system compared with the striatum. Therefore, more Seroquel remains bound to the D2 receptors without being knocked off. This may be why Seroquel reduces the positive symptoms of schizophrenia and the symptoms of bipolar mania. In contrast to the blocking of the D2 receptors in the limbic system, Seroquel is thought to cause an increase in dopamine levels in the prefrontal cortex, the area of the brain associated with the negative and cognitive symptoms of schizophrenia. This effect occurs indirectly through the partial activation of 5-HT1A receptors. It is this partial activation of the 5-HT1A receptor by Seroquel that can cause dopamine in this area of the brain to be released, with the end result being an increase in dopamine activity. It is believed that this may explain Seroquel's ability to reduce the negative and affective symptoms and improve cognition in patients with schizophrenia, and also improve the depressive symptoms associated with bipolar disorder. The actions of serotonin in the pathways involving the limbic system, the striatum, the prefrontal cortex, and the cortex are thought to be mediated by both the 5-HT1A and 5-HT2A receptors. Within these pathways, Seroquel binds more tightly and for longer to the 5-HT2A receptor than the dopamine D2 receptor. This may explain why Seroquel may be effective in bipolar depression at a lower dose. Through its unique mechanism of action, Seroquel, the clever molecule, reduces the positive, negative, and cognitive symptoms of schizophrenia and is effective in treating the symptoms of bipolar disorder while minimizing side effects.